Want to just briefly introduce this afternoon's talk and give you an opportunity to kind of get an overview of what I'm hoping we can do together here this afternoon. I'm really thankful to be here with you. Thank you for having me to kind of give you an overview of eating disorders in primary care and in community-based clinics. I'm really hoping that today's talk will be something that will provide you with tangible resources and information for you to be using in your everyday clinical practice. One of the things we're going to go ahead and have you do, if you have not already, is to go ahead and register for us, please. I've put a QR code here available on the screen, and you can go ahead and you can scan that with your phone, and it'll bring up our registration link. So if you would go ahead and just take a moment to do that for us, we'd really appreciate it. It allows us here at the National Center Eating Disorders to metrics that SAMHSA wants us to report on. So one of our primary focuses is on providing education and training offerings to a variety of folks. And one of the ways that we're able to track a progress by tracking the folks who've registered for our trainings. So please go ahead and scan that QR code and fill out that registration form for us. While you're doing that, I will just briefly introduce myself since I know we've not had a chance to meet. My name is Dr. Christine Peet. I'm the director of the National Center of Excellence for Eating Disorders, and I'm an associate professor of psychiatry at the University of North Carolina at Chapel Hill. I am a clinical psychologist by training and have really spent the majority of my career focused on treating eating disorders and also researching them. And so today I'm excited to be able to share a few things with you. I'd like to be able to talk a little bit about how eating disorders might present in your practice. I understand that many of you are working in primary care clinics or in community-based settings. And so I want to talk a little bit about what eating disorders might look like for you. I also want to talk a little bit about evidence-based tools that we can use to detect eating disorders in your practice. And we'll discuss a little bit about how to provide best care practices for eating disorders in these primary care and community-based settings. And hopefully we'll have some time for some good questions and answers at the end as well. Right. So in terms of just setting the stage, one of the things I think is shared understanding of the prevalence and the impact of eating disorders here in the country. So what you'll see presented on this slide this afternoon are some prevalence estimates that were developed here in 2020, actually. Deloitte Economics partnered with a couple of eating disorder organizations and estimated that the prevalence of eating disorders in the US is roughly 9%. So that means that roughly 28 million Americans are going to struggle with an eating disorder at some point in their lifetime. So this means that about 9% of this population will struggle with something like anorexia nervosa, binge eating disorder. And I think it's really important that we're thinking about this as an important kind of prevalence estimate, because I think oftentimes we think about these as being more rare conditions when really they're not. One of the other things that I think is important for you to be aware of is that eating disorders are life-threatening conditions. What you can see here on the bottom left is that eating disorders are estimated to result in over 10,000 deaths a year, and it's estimated that one person will die every 52 minutes as a result of their eating disorder. The other important thing to highlight here is that eating disorders affect everyone. This means that all ages, all races, all genders, anyone can struggle with an eating disorder, despite the fact that there is sort of this stereotype of an eating disorder really only affecting young, thin, cisgendered white women. The other piece of information that I think is important to highlight from this particular report was an estimated economic cost. This same report found that eating disorders cost the U.S. economy roughly $64 billion in a year. And this is attributable to both treatment costs, which you can see on the left-hand side of your screen, and also cost to the economy or to society. So on the left-hand side of your screen, you can see that there are costs associated with ER visits, inpatient hospitalizations. But in addition to that, on the right-hand side of the screen, you can see that there are important losses with respect to being out of work, having to take time off to care for a sick or a loved one, maybe in the hospital. So collectively, what we're really learning here from this type of report is that eating disorders are common, they're life-threatening, and these are conditions that are incredibly costly to our society. So what are we talking about then when we talk about eating disorders? What kinds of conditions are we referring to? Um, One of the first things I want to highlight is a diagnosis called Other Specified Feeding and Eating Disorder, or OSFED. In a primary care clinic, this is actually the most common eating disorder you are likely to see. This is a diagnosis that sort of is conceptualized as disordered eating. So this idea that people might fall somewhere on a continuum of not having an eating disorder to having a full threshold eating disorder and falling somewhere in between. This somewhere in between territory is what we think about as OSFED. People may have a handful of symptoms from one diagnosis, a handful of symptoms from another, and that's really most commonly what you're going to see in a primary care setting. In specialty clinics, by contrast, individuals may come with already a diagnosis of a specific sort. They may come to you with a diagnosis of anorexia nervosa, bulimia nervosa. However, in a primary care setting where many times people are not even aware that they're struggling with an eating disorder, it's much more likely to kind of be this OSFED kind of presentation. One of the other really common diagnoses that you will likely see in a primary or community-based setting is what's called binge eating disorder. Binge eating disorder is a diagnosis that's characterized by these recurrent binge eating episodes. Now, when we talk about binge eating episodes, I think it's important that we have a shared understanding of what we mean when we refer to a binge episode. It's really not about the amount of food that's being eaten, because that can really vary from person to person. But when we talk about a binge eating episode, we're talking about a time during which someone feels out of control with respect to their eating. They feel as though once they've started to eat, they can't stop themselves, even if they wanted to stop, feeling as though they couldn't. And it's that loss of control that's really the hallmark of a binge eating episode. So for folks that struggle with binge eating disorder, they're having these recurrent episodes of binge eating where they're feeling out of control and then almost invariably feeling guilty, ashamed, disgusted with themselves afterwards. Anorexia nervosa is another common eating disorder diagnosis that is defined by an intense fear of gaining weight or becoming fat, such that individuals are really significantly limiting their overall dietary intake. These are folks that are finding that maybe they're cutting out whole meals throughout their day, maybe they're cutting out whole food groups, and people may lose really significant amounts of weight to the point that they may even become underweight or malnourished. Bulimia nervosa is another eating disorder diagnosis that is also characterized by binge eating episodes, but these individuals pair their binge eating episodes with a behavior that we would call an inappropriate compensatory behavior, meaning they would have a binge eating episode and then maybe follow that up with self-induced vomiting or misuse of laxatives, diuretics, things of that nature. And so for folks with bulimia nervosa, they really kind of have these binge eating episodes that they then tie with some sort of behavior to make up for those sorts of binges. In addition to that, there is a diagnosis called avoidant or restrictive food intake disorder, or ARFID. And this is a diagnosis that individuals will have when they simply just fail to eat. They're not meeting all of their caloric goals for the day. So these are folks that might find that they have forgotten to eat, they're not interested in eating in some way, or these are individuals who find that eating is kind of an aversive experience for them. So maybe they have difficulties with the textures of food, maybe it's certain smells or colors that are difficult for them. Other people also report having scary experiences when they eat. So maybe they have found that, for example, they've had a choking experience when they've eaten, or they've gotten really nauseous when they've eaten. So these individuals will end up not eating because of those sorts of experiences. So unlike anorexia nervosa, these individuals don't necessarily have a fear of gaining weight. They're not afraid of, quote unquote, becoming fat, but these individuals are not meeting their nutritional needs to the point where they become really malnourished or ill. So in a primary care setting, what are some of the warning signs you should be looking out for? I've listed some of these here on this slide, and they're available for you to review. I won't read all of these out loud because you'll have access to these slides afterwards. But what I will say is that when it comes to warning signs, there are some things that should make you more curious or kind of have you perk your ears up when it comes to eating disorder diagnoses. So for example, if you're noticing that a patient is gaining or losing weight, so weight changes in either direction, that may be a warning sign for an eating disorder. If you have folks that are coming to you and saying, I've decided to go vegan overnight, or I've decided to go keto or completely cut out carbs or whatever it might be, it's not always necessarily the case that that individual will for sure have an eating disorder, but I think it's a warning sign that's worth noting and for you to kind of prick your ears up and pay more attention to over time. Some of the other warning signs are listed here on these slides. However, I think it's important that, again, we're following this up with good clinical clinical questions and not necessarily just relying on these warning signs. These may be signs that there's trouble ahead, but not necessarily being diagnostic in nature. In terms of eating disorder diagnoses, in terms of eating disorder complications, there are common symptoms and medical complications that are worth you being aware of, especially in your role in a primary care or community-based setting. The first is being fatigued or having just sort of general malaise. This is something we hear very commonly from our folks with eating disorders. Oftentimes, individuals will also display temperature dysregulation. They'll have cardiovascular issues, endocrine issues. Really, there isn't any body system that is spared when it comes to eating disorders. And so when you as a physician or as a medical provider are thinking about how to be detecting these sorts of symptoms, it's important to be thinking about virtually every body system when it comes to an eating disorder. In addition to that, we often will hear that individuals have gastrointestinal complaints. So many people will talk about being constipated, having, bloating or diarrhea, all kinds of just sort of functional GI symptoms. But these are things that often will coincide with an eating disorder diagnosis. In addition to that, many individuals with eating disorders will end up having psychiatric comorbidity. Many people with an eating disorder diagnosis will also have anxiety or depression. You can see some of the estimates that are here. Somewhere between 70 and 80% of individuals with an eating disorder will also have one of those two diagnoses. And importantly, many people who are struggling with substance use disorders also struggle with an eating disorder diagnosis. For example, there are many individuals who will report having bulimia nervosa in addition to an alcohol use disorder, for example. And some of these combinations can be particularly dangerous, given that we know that if you are malnourished or aren't necessarily getting in your caloric needs throughout the day, and then you're abusing alcohol, there can be some really deleterious effects on the system. One of the things that I wanted to highlight when it comes to the impact of eating disorders is that these are conditions that are really characterized by not just abnormalities in your eating habits or in the way that you experience your body, but these are conditions that are associated with pretty high degrees of functional impairment. So people with eating disorders aren't necessarily just choosing to engage in these behaviors because they have nothing else to do, but the idea here is that these are serious conditions that can have significant impact on your daily life. There was a survey that was done through the World Health Organization across 14 different countries and several different income levels. And these individuals were administered the Sheehan Disability Scale to assess illness severity in each of 4 domains. And what I want to show you here on the next slide is a couple of important things. So on the first, on the left-hand side of your screen, you'll see some of the different domains in which individuals experience severity of their illness, whether that's at work, in their home life, in their social life. And on the top of the screen, you can see the percentage of individuals who are reporting any impairment in those domains, and also the percentage of individuals who are reporting severe impairment in those domains. And what I think is important to highlight here is that when it came to individuals with binge eating disorder, almost half of those individuals in this survey were reporting some degree of impairment in those 4 domains. But even above and beyond that, 13% of individuals were reporting severe impairment, so having really significant difficulties in one of those 4 areas. The most notable from these data were difficulties in your social life. People with binge eating disorder were reporting, roughly 38% of those individuals were reporting any degree of impairment, and 8% were saying that they were having severe impairment in their social life. I highlight these data for a couple of reasons. Number one, I think it really helps to paint a better understanding of the global impact that an eating disorder can have on an individual's life. It's not just their eating habits. It's not just their relationship with their body. It's much larger than that. In addition, we also know that eating disorders are conditions that thrive in secrecy. These are conditions where individuals are going to be really motivated to hide or conceal their behaviors. And so you can imagine that if you're engaging in eating disorder behaviors on a daily basis, that can have pretty significant impact on your social life, make you feel further isolated, and it can make it difficult to reach out for help when you need it. One of the other things I think is good for us to be focusing on, particularly in a primary care or community-based setting, is to really challenge the stereotypes that exist about eating disorders. As I mentioned at the top of the hour, one of the really predominant stereotypes about eating disorders is that the only people that struggle with them are young, cisgendered white women. However, in reality, people that have eating disorders look like many of the people that you see here represented on your screen. They're people of all walks of life, all ages, all body sizes, all races, all kinds of sexual and gender identities. And I think that when you're in a primary care or community-based setting, it's important to be thinking about screening for eating disorders in a broad fashion and not just based on some of the stereotypes that are out there. One of the other pieces of information that I think drives some of these points home is the 9 truths about eating disorders. This was actually a document that was developed by the Academy for Eating Disorders that really helps to bust some of the myths that are out there about eating disorders. I'm probably not going to spend a lot of time going over each of these truths, but I think it's important to highlight a few things. Number one, the truth number one, I think is incredibly important, that many people with eating disorders may look healthy, but they may be extremely ill. I think this really helps to bust that myth that you can tell that someone has an eating disorder just by looking at them. We know that, in fact, the majority of people with eating disorders will look healthy. They may not necessarily have abnormal lab values. These may not be people who are extremely thin or underweight. So I think remembering to screen all individuals, irrespective of how they appear, can be an important practice when you're trying to screen for eating disorders. We also know that eating disorders are health crises, as is represented in truth number 3. These are not conditions that can wait to be treated. The comparison that we often use in the eating disorder field is that individuals with eating disorders need treatment as quickly as they possibly can get it, in the same way that we would recommend efficient care for someone who's been diagnosed with diabetes or someone who's been diagnosed with cancer. We wouldn't put off their treatment simply because it was an inopportune time. We would encourage them to seek treatment as soon as they possibly can. And the same is true for eating disorders. And then one of the other important parts that we haven't had a chance to discuss as much is the importance of the interplay between genes and environment when it comes to who's at risk for eating disorders. We know that individuals with a family history of eating disorders are at increased risk. Individuals with family histories of anxiety and depression, the comorbidities that are very common, these are all things that can place someone at higher risk for developing an eating disorder. However, we also know that genes are not destiny, right? That certainly you can have things that you are genetically predisposed to, but that you won't necessarily go on to develop. The truth number 9 is the other one I really want to highlight. And I think it's important for those of you that are in a primary care or community-based setting. And that's that full recovery from an eating disorder is possible. These diagnoses are not death sentences. People can and do get better from these conditions every day. But some of the most important pieces in getting better or recovering from an eating disorder is having early detection and intervention for those conditions, which is part of why I'm really pleased to be able to work with clinicians who are on the front lines. Also, when it comes to marginalized populations, which I think is certainly of interest here in Alaska or in other rural communities, we know that if you don't fit the stereotype of who typically has an eating disorder, you may not necessarily be detected for that eating disorder. What you can see here is based on a study that the National Eating Disorders Association did many years ago, and they presented a case study of someone with an eating disorder to a group of clinicians, and they asked the clinicians to diagnose whether or not this person had an eating disorder. In the first case presentation, the woman was identified as a white woman, and 44% of those clinicians identified that the individual had an eating disorder. When they changed the race of that woman to a Hispanic woman, that the prevalence of individuals diagnosing an eating disorder went down to 41%. But then when you change the race to that of a Black woman, only 17% of those same clinicians identified that this woman's eating behavior was problematic. So again, I think that there are some real blind spots when it comes to diagnosing eating disorders, particularly at the intersection of race. One of the pieces that I want to highlight here on this slide is when it comes to binge eating disorder, there may actually be an increased risk for binge eating disorder among racial and ethnic minorities. What you can see here is from a community sample, these researchers found that binge eating disorder prevalence was actually greater among Latina individuals and African American women than they were among their white counterparts. So even though we often think about eating disorders primarily affecting white women, the research is now indicating that ethnic and racial minorities may be at increased risk for things like binge eating disorder, for example. The same is true when it comes to eating disorders, gender, and sexuality. We know that even though the stereotype is that women will struggle with these conditions, that men can and do struggle with eating disorders in a very similar way. And so I think that when we're thinking about who to screen and how we intervene, again, it's important to be thinking about casting a wide net. Also, for those of you who may be working with trans communities, I think it's really important to be considering doing routine eating disorder screening with these individuals. We know that roughly 7% of these individuals will report eating disorder symptoms. And my sense is that this is a gross underestimate because eating disorders are conditions that are already sort of shrouded in secrecy. And many individuals who are in trans communities are often reluctant to come forward to participate in research studies, just given the increased stigma and frankly, the safety concerns that they often have. But many individuals who are in the trans community may be engaging in eating disorder symptoms in order to suppress secondary sexual characteristics. So to diminish breast growth, to change their hip size, prevent feminization of facial features. But certainly eating disorders can occur separately from some of these body image concerns. So it's not as though they always go hand in hand, for example. So in terms of how do we sift through all of this information when it comes to the prevalence, the impact of eating disorders, how they might present in marginalized communities? We know that eating disorders have the second highest mortality rate of any psychiatric illness. It's really secondary only to opioid use disorder. So we're talking about very serious life-threatening conditions. And unfortunately, many of these individuals will die by suicide. Even more challenging is that even though these are life-threatening and common conditions, only about half of those individuals with an eating disorder will ever receive treatment in the first place. And so I think there's certainly a lot of room for improvement when it comes to making sure that folks with these conditions receive the care that they need. But even if they can receive this care, actually getting access to it can be really difficult. That's true not only here in a more rural state like Alaska, but it's true in the contiguous US and in major metropolitan cities. The number of individuals who specialize in eating disorder treatment far diminishes the number of people who actually need that sort of care. When we're thinking about why it's hard to get folks into treatment, I think it's important to think about the barriers to detection. Some of them we've already talked about with respect to those stereotypes about eating disorders, but we also know that in general, people tend to downplay their mental health symptoms over their physical health symptoms. I'm sure many of you have seen this in your community where folks may be struggling with symptoms of depression or anxiety. And these are symptoms that are very common across the nation, but people may, instead of talking to you about their cognitive features, will talk to you about the fact that their stomach feels upset or like it's in knots, or maybe they're coming to you and saying that it feels like their heart is fluttering or that they can't, or they're feeling short of breath, right? These are very common symptoms of anxiety, but many people feel more comfortable talking about those physical health symptoms more so than the other sort of mental health symptoms. And that's certainly true for eating disorders as well. Above and beyond all of that, we also know that people with eating disorders are often reluctant to disclose their symptoms. It's not as though people wake up in the morning and say, I have an eating disorder, I'm going to go to some local hospital and get treatment for it. In fact, many people, when they know they're struggling, are actually really motivated to not disclose those symptoms, to keep this sort of in the shadows. As I mentioned before, eating disorders are conditions that really thrive in secrecy. And so disclosing them can really sort of feel like a threat to the eating disorder. Also, I would love for the clinicians here in this audience to be aware that a lack of insight is pretty common with folks who are struggling with eating disorders. So not only are they going to be reluctant to disclose their symptoms, if they're approached about their symptoms, sometimes there can be a real disconnect between what you are seeing as a clinician and what the patient is willing to kind of own up to, or is frankly even able to see in themselves. One of the things that we'll often hear from folks is that only people who need hospitalization really have an eating disorder. I don't need to be in the hospital, so I must be fine, right? Or everyone's always on a diet. Why is what I'm doing any different from that? Why would this be cause for concern when it seems like everyone around me is doing some sort of restrictive diet? People say all the time, well, my lab values are fine. You know, my doc just, took my blood and ran my lab values and everything looks okay. So it can't possibly be this dangerous. But the reality is that eating disorders are tricky. And the body, as many of you know, is designed for homeostasis, and it is going to try and even itself out. So even when you're malnourished, even when you've been struggling with an eating disorder for some period of time, your body fights to try and keep things copacetic. And so those lab values can be really deceiving, in addition to the fact that many people with eating disorders may not even realize that some of what they're doing actually is an eating disorder behavior. However, the good news and sort of all the bleak discussion that we've had so far is that you really are in a position to make a big difference because early detection for an eating disorder is key. We know that patients rarely will come to somebody like myself to receive treatment for an eating disorder just all on their own. They usually end up getting a referral from their primary care provider or their community-based clinician. And one of the real advantages to that is that many times you have an existing relationship with these patients. You may have been taking care of them for years. Maybe you've taken care of their family for generations. And I think that having that existing relationship can really help to kickstart treatment and allow patients to feel comfortable with the idea of maybe seeking specialty care. Because if their trusted doctor, their trusted medical professional is saying, I think you need this, and here's why I think so, that may make them much more open to that sort of discussion in the long run. And again, as with most things, with whether it's mental health or physical health, we know that the earlier the diagnosis and the treatment takes place, the better the overall prognosis. So some of you in here may be wondering what sorts of screening tools you might use when it comes to screening for eating disorders. And I've listed a few of those here, in addition to how you can access them through PubMed. One is called the SCOFF. The other is called the Eating Disorder Screen for Primary Care. And another is Binge Eating Disorder Specific, and that's called the Binge Eating Disorder 7. And we're going to go through each of those in turn. The first is the SCOFF, which is basically an acronym for each of these 5 questions that you see represented here. First, about asking about self-induced vomiting, whether or not someone has lost control over their eating, kind of referring to those binge eating episodes, recent weight loss, feeling as though you're too fat, even though others don't feel that same way, and whether or not you would say that food dominates your life. This questionnaire has actually been demonstrated to be particularly robust in a primary care setting in terms of screening for eating disorders. And a positive screen would be indicated if someone says yes to 2 or more of these 5 questions. Another more recently developed measure is called the Eating Disorder Screen for Primary Care. And you can see the questions that are represented here are a little bit more broad in nature. They're not so focused on specific eating disorder behaviors per se, but they ask more globally about being satisfied with your eating patterns, whether or not someone has eaten in secret. The other interesting thing here is that you can see that they're asking about history of eating disorders in the family, but also a personal history of eating disorders. Again, this is a 5-question measure that has been demonstrated to be accurate for use in primary care, although there's much less research on this particular measure than the SCOFF. The 2 questions that you can see there with an asterisk are what were indicated as the most sensitive items in terms of picking up on an eating disorder. So when they sort of went through and looked at each of these individual items, they tried to determine which 2 would kind of give you the most bang for your buck. And the 2 that have an asterisk there were the 2 that were found to be the most sensitive at picking up an eating disorder in a primary care clinic. Here's a quick screenshot of the Binge Eating Disorder 7. I won't necessarily read all of these questions aloud, but suffice it to say that these are questions that are helped to narrow in on whether or not somebody is engaging in these binge eating episodes, as we had discussed, and then ruling out individuals who may be using some of those inappropriate compensatory behaviors like self-induced vomiting, abuse of laxatives, those sorts of things. Now, the good news is that we here at the National Center of Excellence for Eating Disorders have developed an entire protocol that will allow you to screen for eating disorders in primary care or community-based settings. It will give you what you need to briefly intervene with these patients and then make a referral to specialty care. So many of you in here may actually be familiar with what's called the SBIRT model, screening, brief intervention, and referral to treatment. It was initially developed for alcohol use disorder and then broadened to substance use disorders in general. And so we've taken that existing framework, which we know works, we know is an evidence-based approach. We've simply taken that framework and swapped the content out so that now it's relevant for eating disorders. So within 3 clicks, you can screen a patient for an eating disorder. You will be provided with ways and words that work. So how do I have a conversation about the fact that my patient has screened positive for an eating disorder? And we've given you a one-stop shop in terms of referring patients to the specialty care that they need. In addition to that, there are resources that face patients. So what are some of the support groups you can join? What are the self-help approaches you can have access to? We've really tried to make this as easy to use as possible. It is publicly available on the web. Then you can see the hyperlink that's here at the bottom. You'll receive these slides at the end of today's presentation as well. So you won't need to take notes on all of this. We'll make sure that it gets to you. But suffice it to say, this tool is something that was developed specifically for use in primary care. We worked in collaboration with primary care physicians and other medical providers providers to ask about what sort of approach would be most feasible. What would you actually use? What would be helpful? And this is what we came up with. So please feel free to use this in your practice. This is live and ready to go. So we're eager to receive feedback as well. If you do end up using this and you'd like to let us know how it's working or how it's not working, please feel free to reach out, and my contact information will be here at the end of today's presentation. When you're thinking, though, about how you might detect eating disorders in your patients or who you might decide to do this screening with, as I mentioned before in some of the warning signs, you'll want to think about any patients that are describing concerns about their weight or shape to you. Maybe they're coming to you and saying, listen, doc, I'm unhappy with the way that I look, and I think I need to go on a diet, right? It's not necessarily the case that that individual will have an eating disorder, but it's worth being curious about. It's worth asking about in terms of what's motivating some of these changes for them. As we've mentioned before, individuals with comorbid diagnoses like anxiety or depression, GI complaints, this sort of interplay of these kinds of symptoms really oftentimes will put someone at the intersection of an eating disorder. So it's certainly worth considering screening some of those individuals as well. If you were to ask me or anyone else in the eating disorders field who should be screened for an eating disorder, we're biased and we're going to say everyone should be screened. But I've also listed a few high-risk groups for you all to consider. If you're working in a clinic where you're seeing adolescents, we know that in general, these are individuals that are increasingly high risk for eating disorders. We know that there are just lots of changes that are going on in that period of time that might make someone vulnerable to an eating disorder. And so it's worth doing routine screening with this particular population. In addition to that, patients in key transition periods, folks that might be graduating from high school and going into college, maybe your first job, getting married, your first pregnancy, all of those sorts of transition periods can be really exciting times, really happy times, but also really stressful. And we know that stress is one of those things that makes the ground really fertile for the development of an eating disorder. Patients with any medical morbidity would also be ones to consider screening for eating disorders. Many individuals with diabetes, type 1 and type 2, those with gastrointestinal complaints, PCOS, these are individuals who may be at higher risk for eating disorders, and you'd want to consider screening them on a regular basis. Certainly athletes for a variety of reasons, patients with a family history of eating disorders, patients seeking help for weight loss, as we've discussed at multiple points during this presentation, and then also to the extent to which any of you are working with veteran populations, we've learned over the years that veterans are at increased risk for these conditions as well. Many individuals find that while they're active duty, they're eating in ways that require them to eat really quickly, not necessarily pay attention to hunger and satiety cues. Plus, they have really rigorous physical activity requirements that they have to be engaged in while they're active duty. When they come out of active duty and become a veteran, oftentimes their eating habits don't change. They're still eating really, really fast. They're not necessarily paying attention to hunger and satiety, but they're also not as physically active as they once were. So they may be seeing changes in their bodies that make them then want to engage in behaviors that would help them lose weight. And sometimes they'll do that in ways that are risky or could lead them to eating disorder diagnoses. So if you're a clinician in these settings and you suspect an eating disorder or you've detected one, what do you do next? I think that after that initial screening, it's really important that you as the primary care clinician or the community-based clinician express concern about the fact that your patient has screened positive. I think that screening is something that many of you are very familiar with and very comfortable doing, and this would be no different. When a patient of yours might screen positive for diabetes, or maybe a patient of yours screens positive for high blood pressure, you take the time in the course of that visit to counsel them about why it is you're concerned about these markers and why, as their medical provider, you think they need a certain type of treatment or maybe changing a certain thing in their lifestyle. The same would be true here for an eating disorder. If you have a patient that screens positive, you want to express that same sort of concern and say, listen, I'm worried about you, and I think you might need some specialty type of treatment, and here's why I'm worried about you. With the Expert for Eating Disorders protocol, we've provided you with all of that language and all of the ways to have these conversations to try and take the guesswork out of that. Outside of getting somebody screened and referred to care, we know that primary care docs and community-based professionals are crucial for the ongoing management of eating disorders. When it comes to the treatment of an eating disorder, I'm going to go up a couple of slides. We know that the treatment of an eating disorder is basically a four-legged stool. Individuals with eating disorders need psychotherapy, they need medical nutrition therapy, oftentimes they're being prescribed medications for their eating disorder, but they also need a primary care doc to monitor their physical health. And so you're a really crucial component of the treatment of an eating disorder. And so with that in mind, I'm going to go back a couple slides. I think that when you're a part of that team, having consistent messaging is incredibly important. It's important that you and the therapist and the dietitian and the psychiatrist are all sort of presenting a united front against the eating disorder. You're all agreeing on treatment markers. You're all agreeing on when somebody may need to go to the hospital or not. So it does require a fair amount of communication with various members of the team. But again, I think it's really important to do so that the eating disorder is able to be treated effectively. Referring to specialty care can be a little bit of a minefield, but again, we're trying to make that a little bit easier for you with the Expert for Eating Disorders protocol. So a couple of things to flag here for you. When you're making those referrals, just be prepared that patients may not necessarily jump up and down with joy about the fact that they need to be referred for specialty care. We've talked about how eating disorders are conditions that thrive in secrecy, and what you're doing here is shining a big bright light on it, and that can feel really scary for the eating disorder. So you may recommend that they get referred to specialty care and then they don't do anything with it. Maybe they just let that paperwork kind of sit in their house. So be prepared to have to follow up regularly about that referral to make sure that folks are actually following through. And again, just sort of being aware that getting somebody referred is not as simple as, making a couple of clicks in your electronic medical record or whatever it might be. Especially in a more rural state like Alaska, it may be harder to find some of those resources, and it requires some degree of persistence. In addition to that, we also know that there are a number of other structural challenges when referring to specialty care. There may actually be resistance from the patient themselves or from parents. Having to coordinate care out of state is something I'm sure many of you are very familiar with, and it just adds an extra wrinkle when you're trying to get folks referred. Insurance coverage, especially if you have folks on Medicare, Medicaid, those things can be really difficult, especially if you're thinking about higher levels of care in a hospital or other type of inpatient setting. In terms of what care looks like, there are a number of different levels that you can see represented here on the screen. There's everything from as low as outpatient care, where a patient might be seeing their therapist once or twice a week, in addition to their dietitian, other folks on their team, all the way through inpatient hospitalization, where folks are on a medical floor, they're on a locked inpatient unit, and they're essentially needing to be medically stabilized for their eating disorder. These types of care can be hard to come by, especially after the pandemic, when wait lists have just grown exponentially longer across mental health, but certainly within eating disorders. But this just gives you a little bit of the landscape of what treatment might look like for your patients that are struggling with eating disorders. Above and beyond that, we know that the treatment of an eating disorder is largely psychologically based. The treatments that we have for anorexia nervosa, bulimia nervosa, all the other diagnoses we've talked about largely involve your patients being in therapy. I won't probably go into a ton of detail about those interventions here. I think that's a little bit outside of the scope, but I'm happy to answer any questions that may come up. But suffice it to say that cognitive behavioral therapy, which I'm sure many of you are very familiar with, has been developed specifically for eating disorders. For children and adolescents with eating disorders, there's a specific type of psychotherapy called family-based therapy. Please note that this is different from general family therapy. This is a specific eating disorder family-based therapy in which parents are really heavily involved in getting their children well under the guidance of an expert psychologist or therapist to deliver that treatment. The couple of exceptions to this are that there are two medications that can be prescribed for the treatment of an eating disorder. The first is lisdexamfetamine for the treatment of binge eating disorder. Many of you in here are familiar with lisdexamfetamine for the treatment of ADHD. And then also fluoxetine for bulimia nervosa. Again, I don't think that there's the idea here that, you prescribe a medication and someone automatically gets better from their eating disorder. That is the case for some individuals who receive these treatments. However, I think for many individuals, receiving these sorts of pharmacological interventions allows them to make good progress in their therapy interventions as well. So oftentimes these things will go hand in hand. In addition to that, in the wake of the pandemic, there's been increased access to virtual care or telehealth, which I'm sure many of you are here are doing. And we're all meeting here virtually today. And there have been a couple of eating disorder groups that now provide entirely virtual eating disorder treatment. I understand here from my colleagues here in Alaska that the first one that's listed here, Equip Health, is up and running here. However, the last two are not up and running in the state yet. So I imagine it will only be a short amount of time before they are operating here in the state. So when you receive these slides, please feel free to visit their websites to learn a little bit more about their reach. We've talked a little bit about this already. And so when we're thinking about that four-legged stool, I think it's also good for you to be thinking about how you might work with a specialty team. Let's say you've screened a patient for an eating disorder, you've gotten them referred to care with a specialty team. Now what's your role? What is it that you do? As I mentioned before, that good, consistent communication is really important to have when you're part of this specialty team. Also thinking a little bit about if you have a patient who's in the hospital, what does their discharge plan look like? How often they're going to need to see you on an outpatient side to monitor their physical health, to make sure they don't need to have to go back to the hospital, for example. Also be aware that when you're referring to a specialty program for eating disorders, that there is a difference between referring to that specialty team to simply have your patient evaluated and then a referral to have that patient actually picked up for treatment. There are many centers like the one at UNC where I work at that can do routine evaluations to rule in or rule out an eating disorder, but we can't possibly pick up every single patient that's referred our way because we don't have enough staff to do so. So be aware that it may actually end up being the case that a team will do the assessment and the evaluation of your patient, but then refer them to other community providers. So just be aware that there are some nuances there when it comes to that sort of care. I also wanted to leave you with a few resources for those of you who are interested in learning more. As I mentioned at the top of our talk, NSEED provides a wealth of different resources and many that I think would be of interest here to this audience. So this is a quick screenshot of our resource library. And you can see here on the left-hand side of your screen that you can filter the resources that we have based on what type of provider you are. So if you click on medical provider, it will filter so that all of the resources you're seeing are germane to your scope of practice. Maybe you're interested in a specific diagnosis. You can further sort of filter out the other results that you're not interested in. So please feel free to take a look at that on our website. And those are all freely publicly available for you to use. For those of you that are interested in getting more hands-on training in terms of how you might manage these conditions in your everyday practice, we have a training library that offers free continuing education units, and you can access all of these trainings on demand. We've done a number for those in the primary care or community-based setting, so I encourage you to check those out. I also wanted to leave you with a few QR codes for some relevant resources from today's discussion. The first is a direct link to the Esprit for Eating Disorders protocol that we discussed here this afternoon. The second is to some of the treatment guidelines that I think might be of particular interest for those of you here who are in a primary care or community-based setting. So with that, I will leave you with my email address and open the floor up for any questions that there might be. Also, certainly, please feel free to visit our website for other information or trainings. One ask that I have of everyone here is that when you registered for today, please send an email to Courtney Pierce, our research assistant, with your name, the date and time of today's presentation. If you are requesting CE or CME, please include that in that email. That's the only way we'll know if you need CE or CME. So you'll want to send an email to Courtney to let her know. And if you are dialing in by phone, let me check and see if anyone is, you know what, I actually can't see if anyone is dialing in by phone, but if you are joining us simply by your telephone, please indicate what number you've used to dial in, because we got to match you up to the phone number that's listed here. So just a little bit of housekeeping. We appreciate your attention with that. But for those of you that are requesting CE or CME, it's really important you send this information over to us. So with all of that, I'd like to open the floor to any questions that there might be from today's presentation. And I will just take a look here in the Q&A. If you do have questions, please feel free to put those in the Q&A and I will answer those here live with you all. Oopsie. All right. And for those of you that do have access, please feel free to put any questions that you have into the Q&A. And while we're waiting for questions to come in, I'll just do a brief summary of some of the activities that NCED has been able to do here in Alaska over the last few days. We have been working with the Alaska Eating Disorders Alliance to bring some educational trainings to various parts of the state. So we've been in Fairbanks, we're currently here in Ukiakvik, and we'll be back in Anchorage in a couple of days. And really what we're trying to do is focus on bringing these sorts of educational trainings to communities that may not necessarily have access to specialty treatment centers like you might have in other major metropolitan cities. And so we had some great conversations here this last night and this morning here at the college, hearing a little bit about how eating disorders or challenges with your eating are showing up in the student community, the sorts of resources that could be useful in terms of providing assistance to students that they might be concerned about. And some of the highlights, I think, have been really just having a better understanding of the ways in which rural communities or indigenous communities may be experiencing eating disorder symptoms or eating disorder behaviors in ways that aren't always captured in the research. They're not always captured in sort of the mainstream media discussions about eating disorders. But it's really important that we're equipping these clinicians and these other professionals with this information because they're in a position to be able to provide that sort of help. So we did a session this morning with the student affairs staff and had the opportunity to really drill down into some detail with them about the sorts of resources that would be useful, in particular in a college setting. So we've had that opportunity here today, and we'll continue doing so here at Ukiakvik, and we'll have some continued discussions with folks as the week goes on. So certainly if there are questions about any of that, we'd be happy to entertain those as well. All right. Yep, I'm happy to have some of our colleagues here from the Alaska Eating Disorder Alliance come and give a brief blurb about their organization so that those of you that are here in Alaska and are looking for local resources, they can provide you with some of that information. So I'm going to have Beth Rose come up and just give you a little bit of information about that. We're going to just swap places here 1 second for us.
Thank you, Dr. Pete. I'm Beth Rose. I'm one of the co-founders of Alaska Eating Disorders Alliance, and Jenny Loudon is the other co-founder. And I wanted to let you know that we are a statewide nonprofit focused on eating disorders education and resources, support, and advocacy. We have a website, which is www.akeatingdisordersalliance.org. And on that website, there are local resources, and there's listings of doctors, clinics, therapists, and dietitians who are in Alaska or can provide service in Alaska. Additionally, we have weekly clinician-led support groups for adults 18 plus and monthly support groups for families and friends. So I encourage you to check that out. And if you're interested in some ongoing training with CMEs, we also have a Project Echo, and you can get information at bit.ly/Akita Echo. And the next one that's coming up is October 19th with Dr. Laura Hill on the neurobiology of eating disorders. So thank you for your interest in this, and I'll turn it back over to Dr. Pete in case there's any other questions.
Great. Thanks so much for your patience. All right. So in the absence of seeing any other questions coming in, through the Q&A, what I will do is just make sure that you all have access to today's presentation in terms of the slides. And I'll also make sure that I've got my email address up here. Oh, hang on 1 second. I think I might see one coming in. I see. There is one question coming in, so I'll read it aloud in case you all don't have access to it. As a physical therapist, I often get people who will talk about dissatisfaction with their bodies. Working orthopedic specialists, there is a big focus on losing weight. What advice do you have for me trying to deal with this? My doctor told me to lose weight. Yeah, I come back from a background of personal experience of anorexia, find it especially irritating that medical professionals will will put pressure on people with the support that they need to deal with eating, without the support they need to deal with eating disorders or weight problems. It's a great question. Thank you so much for asking that. And, I think in your particular setting, one of the things I think could be really helpful to focus on is that there's oftentimes an overlap with trying to lose weight and actually engaging in eating disorder behaviors. One of the things that we know is a major risk factor for the development of eating disorders is a history of overweight, history of obesity, history of dieting. And I think that it's just really challenging because some of the messages that we get, particularly in a medical setting, is that what we really need to be addressing is obesity or overweight. I think that there are lots of discussions to be had in terms of how we have better conversations around those pieces. But for those of you that are individual providers, I think it can be really important to say, listen, as an individual, you get to make choices. You get to decide what it is that you want to focus on in your health and in your journey towards health. At the end of the day, though, as a provider, what I'm concerned about is that if you engage in behaviors like cutting out entire food groups, skipping multiple meals a day, abusing laxatives, engaging in self-induced vomiting, those sorts of things, I'm concerned that that's not just sort of trying to lose weight. Those are eating disorder behaviors. And here's why I'm worried about those things. If folks aren't coming to you with explicit discussion of eating disorder behaviors they might be engaging in, I think one of the things you can do if a patient comes to you saying that they want to lose weight or that that's their focus, you can ask them a little bit about what makes that the focus for them. Tell me a little bit about that. Tell me about how that became a priority for you, right? And I think that there are ways to help people engage in behaviors that help support their health and improve their health, but don't necessarily involve dieting, right? So roughly everyone benefits from eating a variety of types of foods, right? Roughly everyone benefits from about 8 hours of sleep a night. Roughly everyone benefits from engaging in some sort of physical activity that they enjoy. That doesn't mean having to chain yourself to a machine in the gym, but just doing things that you enjoy doing in terms of moving your body in some meaningful way. So sometimes, again, if we show a little bit of curiosity, if we spend a little time asking a few questions about what's motivating some of these things, it can lead to really rich discussion and potentially help prevent people from engaging in some of those behaviors that we might consider to be eating disorder behaviors. But thank you so much for asking that question. It's a great one. All right. Well, I know we are getting close to the end of time, so I'm going to give it one more minute just to see if anybody else has any other questions they'd like to throw into the Q&A. All right. I'm not seeing anything else come in. So we will wrap it up here. I just want to say thank you again for coming. We appreciate your attention and taking time out of your busy day to be here with us. We also recognize that we are meeting on Indigenous Peoples Day. So thank you for taking time from your day to be here with us to learn more about eating disorders. And please don't hesitate to reach out if there are any questions. Thanks very much. Take care.